So let's talk about a quick guide for bronchial asthma management in the OPD according to the latest GINA guidelines. Suppose a patient comes with asthmatic symptoms like wheeze, shortness of breath, cough, or chest tightness. The first thing we want to do is a spirometry. The first thing we want to look at is the FEV1 by FVC ratio. If this ratio is less than 0.7 or 70%, we are dealing with a case of airflow limitation, which could be either bronchial asthma or COPD. To differentiate between these two, we want to do a bronchodilator reversibility test. We will give 2 puffs of salbutamol MDI and wait for 15 to 20 minutes, and we'll perform the spirometry again. We will compare the FEV1 from the previous FEV1. If the new FEV1 is found increased from the previous by more than or equal to 12% or more than or equal to 200 ml, the patient improved significantly with the salbutamol. This happens only in the case of bronchial asthma. If it didn't improve to that level, we are dealing with a case of COPD, right? If this is so, we will follow the COPD Goal 2026 guidelines, right? Now, bronchial asthma is of two types, type 2 and type non-type 2, right? So to differentiate this, we will like to send an absolute eosinophil count, total IgE, or FeNO, right? If FeNO is increased, if eosinophil count is more than 300, if the total IgE is more than 500, we are dealing with type 2 bronchial asthma, and it is usually steroid responsive with good prognosis. If none of these are there, we are probably dealing with non-type 2 bronchial asthma, which has poor response to treatments, right? So apart from this investigation, to decide which therapy we should proceed to, we will ask how many attacks happens in a week, right? If it happens in most days, meaning at least 5 times a week, or if there is any night awakenings, at least one in a month, that means the patient has a tendency to have recurrent episodic exacerbations. In this case, we will give daily maintenance therapy with additional reliever therapy SOS if there is any exacerbations in between, right? If none of these are there, that means the patient doesn't have much tendency to have recurrent episodes. In this case, we will not give daily maintenance therapy. It's not required, right? In this case, whenever the patient has such episodes, we will prescribe them low dose inhalational corticosteroid formoterol therapy SOS, right? This is the preferred regimen or track 1. They can also use a SABA plus an ICS reliever therapy SOS, and this is the alternative regimen or track 2, right? Now, in the previous case, we have come to the point that the patient requires a daily maintenance therapy. To decide how much dose the patient should be given, we will look into FEV1 value, right? If the FEV1 is more than or equal to 30%, we will give a low dose ICS formoterol maintenance and reliever therapy known as the MART daily, right? And if in between the patient has any recurrence, we will also give the same ICS formoterol as reliever therapy SOS. This is track 1 or the preferred one, or you can choose the low dose isoflurane as maintenance daily therapy with a SABA reliever therapy SOS. This is alternative regimen, right? So after following up at 2 to 3 months, if this patient doesn't improve much, or if the FEV1 was less than 30%, he requires medium dose, not low dose, medium dose ICS formoterol maintenance and reliever therapy with ICS formoterol SOS in between if there is any recurrence. Right. If he doesn't improve with this, we will also add a short case oral corticosteroid therapy for 5 days. If improvement is not satisfactory with all this, we will consider biologics. Biologics are different in case of type 2 and non-type 2. So this is a quick overview of how to manage a bronchial asthma case in the OPD. Hope it's clear. Thank you.